Welcome. So a very brief synopsis. We're going to do what is it, the anatomy behind there, risk factors, and treatment for IT band. I see a lot of people with knee pain. So we say IT band syndrome. It's commonly referred to that, but the long name is iliotibial band syndrome. And predominantly, the pain is on the outside of the knee. It's usually this kind of sharper pain in runners. It gets worse with activity, and it's worse in men more than women. So this is just a kind of general synopsis of the prevalence of runners' injuries to the knee or different structures as well. Kneecap pain or runner's knee is the most common one with about 50% of injuries. And we did a webinar on this one a while back. You're more than welcome to take a look at it. IT band is about, I'll just say about 10%. So it's common enough I see in the clinic, but not nearly as common as patellofemoral pain or runner's knee. So the anatomy, this is a very interesting structure. It's a big band on the outside of your leg. So it attaches on the glute and the TFL, this muscle here called the tensor fasciae lata or TFL, and the glute med, which is a little bit deeper to this tissue here. And it goes all the way down on the outside part of the knee, and below the knee, it's where it inserts. So it's a very thick, fibrous tissue. And the purpose of this band is to help stabilize not only the pelvis, but the knee. So when you land, the glutes contract and it pulls the IT band taut and it creates stability in that structure. So if we get down a little bit more in the nuance, this band crosses the knee. So we have the femur, which is a thigh bone, and it goes onto the tibia, the shin bone below. The thigh bone, the femur has something called the condyle, which I'll show you a better picture in a moment, but it kind of sticks out. And this IT band goes on the outside and kind of goes around this femoral condyle or lateral femoral condyle and inserts below. And that's pretty relevant because it could be prone to friction or compression in that area. 30 degrees is a key number we use in IT band issues, in that if your knee is straight, that's 0. And if you begin to bend it or flexion, that's 30 degrees, and more. So when it hits about 30 degrees, that's when the IT band goes from an anterior placement to more of a lateral posterior placement on the knee. So it kind of shifts back and forth or rubs around this femoral condyle. So essentially, it's more prone to friction. Here's the femur. I'm looking at straight on, and I just want to point out the lateral epicondyle, or you can say condyle, and that just means protuberance. And the IT band kind of goes right along there, and it's prone to irritability or pressure along that area. That's kind of the basic anatomy of the IT band and kind of what it's supposed to do in running. Now, we see a lot of issues for the IT band, and the questions are, okay, why? Hip abductor strength, it's a huge one. Training errors, restrictions in quad and IT band mobility, and running form. And we'll go through each of these and kind of tell you what that means. So the hip abductors, we got a few of these, the glute medius, glute minimus, glute maximus, even the TFL. So we got the glute medius is a key hip abductor muscle, and that also attaches on the IT band. Glutes and the IT band help control the pelvis and the knee stability when in contact. When your foot hits the ground, it really helps stabilize those structures, especially the glute medius. And when that is weak, you don't have the stability that is needed. If the glutes are weak, the knee tends to cave in. And as you can tell from the anatomy, the IT band's on the outside. So if the knee starts to cave in, that compression and that friction on the femoral condyle will get greater. So that's why the hip abductors are very important for treatment of IT band and commonly weak in this syndrome. So there's different ways to kind of test a hip abduction, but you can squat, you can lunge or single leg squat, and you can look at yourself in the mirror and just see how is the knee controlled. If you bend down, does the knee cave in? And again, there could be a few factors contributing to that, like restriction in your ankles or just motor control in general. And there are many ways to strengthen the hip abductors, but these are just the tip of the iceberg. I like more functional training with the girl on the right, where you kind of do more hip dips, stuff like that. But essentially, any lateral strengthening to the side. You can use bands where you put your bands around your feet or ankles and go side to side. That's a great one as well. But these are ways you can strengthen it. And we also have on our website different ways to progress, not only test, but progress your strengthening from easy to hard. Training errors. This is very common. So essentially, the tissue's loading capacity is not keeping up with the demands you place upon it. Training errors usually happen about 3 to 4 weeks prior to injury. So if you begin a program, you may not be injured right away, but then with time, it will start to creep up on you. So typically, if you're injured now and there wasn't like a catastrophic injury, probably something a few weeks ago started this process, and now it's barking to you right now. So on the y-axis is injury risk, high and low. On the x-axis, so the bottom one, is training loads, low or high. On the far left is, I call it tissue fragility. So if you're not training, your tissues aren't really that strong or resilient. So as such, if you were to do like, I don't know, run or sport, your injury risk is higher because the tissues just aren't strong enough to withstand those forces. If your training loads are really high, you have a higher injury risk as well. So when we do train, we want to gradually go along and push it a little bit and then back off, and push it a little bit and back off. But as beginner runners, usually I see them on their tissues are fragile, and then they try to overload those tissues really quick. This is time spent in easy versus hard. A lot of it's saying is, hey, most of the run should be easy, and then followed by, sporadic hard days as well. And that will reduce your risk of overload, but also your tissues can increase the capacity as well. Third thing, quad and IT band restrictions. Now, to my first point, the IT band is a very thick fibrous band. And they've done studies that it's very hard to stretch this tissue out. So the thinking goes, say for foam rolling, reducing some of the scar tissue adhesions within the IT band on the quadricep muscle or the lateral quad. So it's not necessarily a length issue for the IT band, more of an adhesion kind of issue. But the IT band and the quad are very interlinked with fascia. And so we find that if you kind of lengthen the quad, it might have a positive impact, at least on the fascia. Sorry, when I say fascia, this IT band is actually a form of fibrous band. And there's stuff in between the band that connects to the muscle too. That's called fascia. So I give my patients kind of a form of a quad stretch. I might bias it with an IT band component, which I'll show you in a moment. But just know that it's very hard to specifically stretch the IT band itself. So this is the way I like to stretch the quad / IT band. And you can't quite see it here, but I bias my knee inwards towards the midline of my body. And my goal is for my foot to hit my glute. So you feel usually decent stretch up front. And it has pretty good benefits that I see on my IT band patients. And the last one is just running form. So this is what I see contributing for IT band issues. And again, it's hard to appreciate if you don't look at runners' form that much. It's more of a crisscross pattern where the foot's kind of lined up over each other or crisscross when running, instead of being necessarily side by side. And so this is a tricky one to see. You can see it in the mirror potentially, or have a running coach look at you, or anyone gives feedback. But if your legs are going inward, again, it could put more strain on that IT band. And so a method I use, if you do this, that I find is go on a running track and you have like the lines on a track, you just kind of focus on bringing your feet by it, but not crisscrossing it. So all that to say is there are many different contributing factors for IT band syndrome. However, there's a lot of interesting running forms that they don't have pain either. This is a female, Priska Jepto. She's a silver medalist, and her form is horrendous, but it works for her. And I imagine she's run like this for her whole life, and her tissues have adapted so they don't cause the pain that someone that just began running like this would cause. So just keep that in mind. It's very hard to get perfect running form, if there is such a thing as perfect running form. It's how we move the most efficiently along. And there could be some corrections along the way. And these are just suggestions that I gave for you for IT band. But again, everyone's a little bit different.